talk about aortic aneurysms. So why are we even talking about this topic is because of the life-threatening complication of aortic dissection. So it's important that we evaluate, diagnose, and follow up these patients. My area of expertise is non-invasive imaging. So we start with the four major modalities: transthoracic echo, transesophageal echo, CTA, and MRI. Those are the four major modalities that we have for diagnosing and following up aortic aneurysms. The two important topics in this area are bicuspid aortic valve as well as Marfan syndrome. These are patients who have an associated aortopathy and who need constant follow-up. So the starting point is almost always a transthoracic echo. You look at the presence of the aneurysm, the location of the aneurysm, the extent of the aneurysm, as well as if there is any associated involvement of the aortic valve and aortic regurgitation. So once you have an initial diagnosis made from transthoracic echo, then we need to go further with maybe a transesophageal echo, especially if you are looking for any involvement of the aortic valve. However, the echocardiographic and sonographic methods have their own limitations. We do need advanced imaging such as coronary CT or chest CTA, as well as cardiac MRI and cardiac MRA. So thinking about chest CTA, the advantages are high resolution and we get precise measurements of the aortic dimensions, and they are great for the initial diagnosis and for follow-up. The disadvantages being there is the finite risk of radiation as well as the need for contrast, which is not suitable for patients with advanced kidney disease. Now that leaves us to move on to the next stage or next method, which is cardiac MRI and chest MRA. The advantages being it's a non-radiation technique and it's safe with no side effects. Obviously, we may need gadolinium, which is the contrast that is used, which may not be suitable for patients with advanced end-stage renal disease. Again, we can establish a baseline and then periodic follow-up based on the extent of the aneurysm, the location of the aneurysm, as well as the size of the aneurysm. It's very important that as much as we evaluate the aorta, we should not forget the aortic valve, and the timing of surgery may also depend on how badly the valve is leaking. Bicuspid aortic valve is a very important entity. These are patients who are prone to develop aortopathy and they need to be closely followed up. Again, the cutoffs for various, the dimensions for surgery can also vary. The classic standard dimension for a patient with aortic aneurysm is 5.5 centimeters. It's the same right now for bicuspid aortic valve in an uncomplicated bicuspid aortic valve patient with aortopathy. However, in a patient with Marfan syndrome, the cutoff becomes much smaller. So in summary, we have modalities that we use, the non-invasive modalities being transthoracic echo, TEE, CT, and MRI. What we use, where we use, it all depends on the availability of the technique and the local expertise, as well as we have to give consideration for the need for contrast and radiation.
GenWorks is here. Together, let's work towards a healthier India.